So today we will take anatomy, and the very first question is like a lady came with a large abscess in the middle of the right posterior triangle of neck. Now the surgeon did incision and drainage for the abscess, but few days later the lady noticed that she could not extend her right arm above her head to comb her hair. Now, here, two things are very important. The abscess is in middle of posterior triangle of neck. Clear? And secondly, post incision and drainage, the lady was unable to comb her hairs. So it means when incision and drainage was done, maybe some nerve was injured so that she couldn't comb her hair. Now what does this movement actually is? Now this movement is abduction of the shoulder beyond 90 degree. Clear? Beyond 90 degree. So it means she cannot abduct her shoulder beyond 90 degree. Now if you know this particular movement, it is carried out by two muscles. One is trapezius and second is serratus anterior. The nerve supply of trapezius is spinal accessory nerve, and I think most of you must be knowing that serratus anterior is supplied by the long thoracic nerve of Bell. Clear? So it means either there is injury to accessory nerve or either there is injury to long thoracic nerve. And if we talk about the anatomy of posterior triangle of neck, there is spinal accessory nerve. So it means in this case there is injury to spinal accessory nerve, and as a result of this there is paralysis of the trapezius muscle. Good afternoon, Dr. SK. So the lady is not able to comb her hair. Clear? So if you look in the diagram, this is the diagram of posterior triangle of neck. So if we suppose if we are drawing on the right side, posteriorly there is trapezius muscle, anteriorly there is sternocleidomastoid muscle, and inferiorly there is clavicle. So this is clavicle. So this is the triangle, and somewhere in middle of the triangle is the spinal accessory nerve. Clear? So if there is any injury to this nerve, there will be paralysis of two muscles. One is of course the sternocleidomastoid and the second one is trapezius. So both these muscles are supplied by spinal accessory nerve. Clear? So this is the answer in this particular question. The lady is not able to comb her hair, it means she can't abduct the shoulder beyond 90 degree, and there is paralysis of trapezius, which is supplied by spinal accessory nerve, which is the content in the posterior triangle of neck. So this is the posterior triangle of neck. Clear? So this is how you can get your answer. Now moving forward, nerve supply of supinator is like which of the following muscles nerve supply? So for this you need to know what is the nerve supply of supinator. and you need to know what are the nerves which supplying the options, and then only you can match which muscle actually has the same nerve supply as that of supinator. So nerve supply of supinator is radial nerve. Okay. Now we need to write down the nerve supply of the options given here. So brachialis is supplied by musculocutaneous nerve. Clear? Biceps brachii is also supplied by musculocutaneous nerve. Fine. Pronator quadratus is supplied by anterior interosseous nerve. Anterior interosseous is a branch of median nerve. So maybe at times you don't have anterior interosseous nerve in the options, you might have median nerve. And brachioradialis is also supplied by radial nerve. So if there is a question which is asking you about the muscle which is having the same nerve which also supplies supinator, the answer is brachioradialis. Clear? Because both are supplied by radial nerve, right? So this question is a little difficult because you have to remember the nerve supplies of all the muscles, then only you can reach up to the answer. Then moving forward, a patient has weak flexor pollicis longus and flexor digitorum profundus of the index finger. Which nerve can be involved? Now here, pollicis word is related to thumb. So it means there is weakness of the flexor muscles of the thumb, which is a long muscle. Longus means long. And flexor digitorum profundus of index finger. So if we write it here, FPL and FDP, especially index finger. Now here, now these two are the deep compartment muscles. Flexor group. Okay. So this is their group, deep compartment muscles. Of course, the third one is pronator quadratus, but we can skip that for the time being. The third one is pronator quadratus. So in the question, flexor pollicis longus and flexor digitorum profundus, and that too specifically of index finger. Now in flexor digitorum profundus, you should know that it is a hybrid muscle, right? So it is supplied by it is getting supplied by two nerves, and this you can write like middle finger. This half is supplied by median nerve. Clear? And the other portion that you can write as ring finger and little finger, this is supplied by ulnar nerve. Right? So are you getting my point? FDP is an example of, very good, Dr. SK. FDP an example of hybrid muscle. It is hybrid muscle, means the muscle is one but it has dual nerve supply. So here you can see the lateral part is supplied by median nerve and the medial part is supplied by ulnar nerve. Therefore, if you look in the question, and also the flexor pollicis longus is supplied by median nerve, pronator quadratus is also supplied by median nerve. Now these three, in median nerve is specifically the anterior interosseous branch. If you want to be more specific, it is anterior interosseous branch. Clear? So suppose if we take the parent nerve here, now here FPL is supplied by median nerve, the lateral half is supplied by median nerve. So the answer in this question would be median nerve. And see, the term for FDP is specifically index finger, because ring finger, little finger is not supplied by median nerve. It is ulnar nerve. Clear? So if there is any involvement of FDP and the question has to be median nerve, that will specifically involve the words index finger and middle finger. Clear? So, and if you want to be more specific, then we can mention anterior interosseous branch. So this is very important to understand here. This word is the catch, index finger, fundus, and this green one is pronator quadratus. And you can see this is the medial half. Okay, so this is all medial half here, and medial half is going to the medial two fingers, and the lateral half is going to the lateral two fingers. Clear? So lateral half is supplied by median nerve, which is going till index finger and middle finger, and medial half is supplied by ulnar nerve, which is going till the ring finger and the little finger. So please remember this anatomical fact. Okay, so this is the flexor digitorum profundus here, and this is again flexor digitorum profundus here. Clear? That's why it's a hybrid muscle. Now on examination, the thumb was laterally rotated and adducted. Now which nerve can be involved? Now here see, if you look at the thumb, it seems like it is slightly internally rotated, slightly. Okay, and the plane of the palm is different as compared to the plane of fingers, the thumb, sorry. So now what happens, if it rotates externally, it comes to lie in the same plane as that of palm. And this is what is known as the ape thumb deformity. This is the ape thumb deformity. Clear? And secondly, the thumb will lie close to the index finger, and that is known as adduction. So adduction and external rotation, this is of course external rotation, or what you call lateral rotation. So this is the ape thumb deformity, and I think most of you must agree that ape thumb deformity is seen in injury to which nerve? This is seen in injury to median nerve. Clear? So this is how you will reach up to your answer in this particular question. And why there is adduction? This adduction is because of one muscle, that is adductor pollicis. And adductor pollicis is supplied by which nerve? This is ulnar nerve. Clear? So here the ulnar nerve is getting overactive, and it is causing the adduction of the thumb, right? So adduction of thumb, this is by a muscle which is supplied by ulnar nerve, because the median nerve is paralyzed. So adduction and lateral rotation of thumb, this is ape thumb deformity. Then moving forward, while eliciting patellar tendon reflex, which tendon is stretched? So if you look here in the image, this is, say, patella. Clear? So this is patella. Then we have the muscle. This is the entire muscle in the anterior compartment of the thigh, right? And then here is the tibial tuberosity. and the tendon attaches to this tuberosity. So this is the tendon here. So this tendon is stroked, and this tendon is known as ligamentum patelli. And this is actually the tendon of the muscle that is known as quadriceps femoris. Now we are using the word quadri. Quadri means 4. So it has got 4 heads. 3 of heads starts with the word vastus. So vastus medialis, outer side will be lateralis, and in between will be intermedius. Clear? So these are the 3. And the 4th one is rectus femoris. Clear? So these are the 4 component. 1, 2, 3, 4. Fine. And when we stretch the ligamentum patelli, there is reflex contraction of the quadriceps, and there occurs extension of knee joint. So this is the example of deep tendon reflex. Clear? So this is deep tendon reflex. So this is how the reflex is elicited. Moving forward, a needle must be inserted into intercostal space. Now what is the preferred site? Now for this you need to understand the anatomy. See, this is upper rib, this is say lower rib. Okay, so this is upper rib and this is lower rib. Now we have to do thoracocentesis and we have to pass the needle. So what we do actually, we have to make sure that when we are passing the Chaitanya, very good. When we are passing the needle, we should not injure the neurovascular bundle. And neurovascular bundle is in the lower part of the rib. Clear? So it is something like this. Fine? So it is in the lower part. And therefore, it is always wiser to pass the needle along the upper border, because this area is safe. Here there is no vascular bundle. So this is upper border of rib, because lower border is related to the neurovascular bundle. So don't pass the needle along the lower border, otherwise you will injure the, yes, very good Dr. SK and very good Dr. Bhavnesh. So don't pass it along the lower border, always choose the upper border, because that way you will not injure the neurovascular bundle, right? Chalo, good. Which of the following does not pass through the aortic opening? Now, aortic opening is a osteoaponeurotic defect. Clear? And this means that the lumen of this opening remains unchanged, whether the diaphragm is contracting or relaxing. And from here, I think most of you must be knowing this mnemonic, ATA. So A for azygous vein, T for thoracic duct, and yes, A is for aorta itself. Clear? So just remember this mnemonic, and I think based on this you can say that phrenic nerve does not pass through the aortic opening, right? So please remember it. Aorta, azygous vein, thoracic duct, they all pass through aortic opening. Please remember it. And again I am stressing, it is not a true opening. Please remember it, not a true opening. It is just a defect through which the aorta is passing. Clear? So please remember it. Then a pediatrician noticed that some green colored liquid matter is coming out through the umbilicus of a newborn. What is the embryological basis? Now this green colored matter is actually the meconium, or what you call the fecal matter. Now this fecal matter has to be in the intestine. So suppose if this is the intestine here, so this fecal matter has to be here in the intestine, right? This is fecal matter. Now as per the question, it is coming out through the umbilicus. So suppose if this is the umbilicus here, this is the anterior abdominal wall, and this is the umbilicus. Clear? So this is, say, umbilicus. So the matter is coming out through the umbilicus. It means there is some communication between the anterior abdominal wall and the intestine. Then only this fecal matter can come out like this. And this tract is actually known as vitello-intestinal duct. And if this is fully present, then only the meconium can come out. So persistence of entire vitello-intestinal duct. So got my point? If that duct is fully, yes, Chaitanya, very good. If it is fully patent, then only the meconium can come outside. Is that clear? So here you can see, this is the gut, this is the anterior abdominal wall, and the meconium can travel all the way only if there is a channel or communication between the anterior abdominal wall and the gut. Clear? So that's pretty obvious. And sometimes you must have heard of Meckel's diverticulum. So this is the Meckel's diverticulum here, and you can see it is also because of persistence of little portion of vitello-intestinal duct, not the entire area. Clear? So please remember umbilical fistula. So this is the umbilical fistula, at times also known as fecal fistula, and the meconium will come out through the umbilicus. Then moving forward, in portal hypertension, there is, obviously there will be opening above portosystemic anastomosis, and one such site is lower end of esophagus, where the patient will have dilatation of veins, which is also known as varices. And since we call it portosystemic anastomosis, it means the veins of the portal system and the systemic veins, they make anastomosis here. Now here in the lower end of esophagus, you have to remember like which vein is from the portal system and which vein is from the systemic system. Now here if you look, this is the lower end of esophagus, and here from the systemic vein, this is the azygous vein. Clear? And the vein which is of the portal system is the left gastric vein. So left gastric vein is the vein of portal system, and azygous vein is the vein of systemic circulation, that is superior vena cava here. So this is systemic circulation. Clear? So this question is portosystemic anastomosis in lower end of esophagus. This is left gastric vein which is participating here, and this is azygous vein which is participating from this region. Clear? Now, please don't mix up portal hypertension. This is portal hypertension which is seen in case of cirrhosis of liver. Patient will have ascites, hemorrhoids, caput medicine, all. And Chaitanya, you are mixing, I think, portal vein. Now, portal vein itself is formed by the union of two veins, superior mesenteric vein, and the other vein is the splenic vein. Clear? So, superior mesenteric vein and splenic vein. So, I can just write the full forms. Superior mesenteric vein and the splenic vein, they join together to form the portal vein. Clear? And this union occurs behind the neck of pancreas. Very good, Dr. SK. So this is formation of portal vein. Clear? Now we are asking about portal hypertension and opening up of portosystemic anastomosis. So the component of portal venous system is left gastric vein. The component of systemic venous system is the zygous vein. So the question is about the which vein is the component of portal venous system, and that is left gastric vein. So here the answer will be left gastric vein. Now a patient has RTA, road traffic accident, and then he came to emergency. There is injury to bulbar urethra. Now if the urine leaks out from bulbar urethra after rupture, what are the areas where this urine can extravasate or where it can get accumulated? Now, I think most of you must be knowing the anatomy of the urethra. There is prostatic urethra, then there is membranous urethra, then there is the bulbar urethra and the penile urethra. Clear? So, prostatic, membranous, bulbar, penile. Now the question is about the rupture somewhere here. So this is bulbar urethra actually. Clear? And here membranous urethra, this is the deep perineal pouch. Clear? So this is the deep perineal pouch. Okay. Now, if there is rupture of bulbar urethra, the urine will come into superficial perineal pouch. The urine can collect around the penile shaft, or the urine can extend up into the anterior abdominal wall. Right. So, superficial perineal pouch is one area where the urine can accumulate. Then around penile shaft it can go, and it can extend into the anterior abdominal wall as well. But it will never go inside the deep perineal pouch. Is that clear? It will never go inside the deep perineal pouch. Please remember this. So many times this question is an all except question, and in those cases the answer has to be deep perineal pouch. Very good, Dr. Puneet. Superficial perineal pouch, penile shaft, anterior abdominal wall. Very perfect, very perfect. Chaitanya, you are also right, superficial perineal pouch, but you need to know other things as well. And yes, if you cannot remember anything, at least remember one fact. If there is a rupture of bulbar urethra, urine will never go into deep perineal pouch. Your purpose will be solved, right? So here, if you see, this is the superficial perineal pouch. It can go into scrotum, it can come around the penis, it can go into the anterior abdominal wall. Clear? Just remember this much. And it will never go into the deep perineal pouch, which is drawn in red here. So this is the deep perineal pouch. The urine cannot come here if there is a rupture of bulbar urethra, right? Then deep inguinal ring is a defect in. Now in inguinal canal, I think most of you must be knowing, suppose if this is the inguinal canal, there are two rings or two openings in fact. This is one and this is the another. So the one which is deeper is deep inguinal ring, and the one which is superficial is superficial inguinal ring. And this is of course the inguinal canal. Clear? So this is the inguinal canal. Now these openings, first thing you should remember that these openings are not present in the muscles proper. These openings are not present in the muscles proper. This is present in the fascia transversalis. Clear? This is present in the fascia transversalis, and this one is present in the external oblique aponeurosis. Clear? So this one is in the fascia transversalis and this one is the external oblique aponeurosis. None of the opening is present in any muscle of the abdominal wall. Clear? So never mark your answer related to any muscle. Deep is in fascia transversalis and superficial is in external oblique aponeurosis. Clear? Very good, Bhavnesh, you are absolutely right. So this is the basic anatomy of the inguinal canal. So deep inguinal ring, okay, so deep inguinal ring and superficial inguinal ring. Clear? Now we can take few more words from here, and if you see here, there is one bony landmark which is actually the point of attachment of inguinal ligament, and this is the pubic tubercle. Okay, so this is very important landmark. So pubic tubercle. Now why I want to discuss this, because if the opening is, and suppose if this is the midline here, okay, this is the midline. If the herniated sac is present here, that is above and medial, this is one possibility. Or the herniated sac can be here, that is below lateral. Clear? So above medial, below lateral. Now if it is above medial, this is inguinal hernia, and if it is below lateral, this is femoral hernia. So clinically, if a patient comes with hernia in clinical practice, and if you want to differentiate the two types of hernia, the pubic tubercle always help us out in this, and we will just feel the herniated matter, the sac of herniated matter, whether it is above and medial to the pubic tubercle, we will say it is inguinal hernia. If we are feeling it below and lateral the pubic tubercle, then it is femoral hernia. Clear? So that is very important in clinical practice. So anyway, these are the two rings. Now there is one landmark, and this is Hasselbalch's triangle. Now which landmark forms the lateral boundary of Hasselbalch's triangle? Now here we can just have a rough diagram first. Now suppose this is rectus abdominis muscle. Clear? This is rectus abdominis muscle. Downward we have the inguinal ligament. Okay, so this is the inguinal ligament, and laterally we have inferior epigastric vessels. So this is the inferior epigastric vessels, both artery and vein. Clear? Now this all area which I am highlighting in yellow is the Hasselbalch's triangle. Clear? So if someone asks you what is the lateral boundary, then the answer has to be inferior epigastric vessels. If someone asks you what is the medial boundary, then the answer has to be rectus abdominis muscle. And if someone asks you what is the inferior boundary, then the answer has to be the inguinal ligament. Clear? So this is how we define the Hasselbalch's triangle. Now what is the importance, surgical importance, and why we discuss it so much? Because this is the area of direct inguinal hernia. Clear? So the herniated bowel is directly coming out from this area and then it is moving out through the superficial inguinal ring. So suppose if there is the superficial inguinal ring here, the bowel is, and deep will be somewhere here. So the bowel is moving into the inguinal canal. This is, say, the inguinal canal. So it's entering through the posterior wall of the inguinal canal and coming out through the superficial inguinal ring. So this is direct. And here the person is elderly. Clear? And there is a prolonged history of chronic history of exertion, like coughing, constipation. So just 2 points to answer direct inguinal hernia: elderly and history of chronic exertion. Clear? So this is direct inguinal hernia. Now moving forward to another question where a male child has presented to the OPD with swelling in inguinal region, and there was herniation of intestinal loop along with the spermatic cord reaching up to the scrotal sac. Now what is this condition? The moment you see the word child, now here the child word is very important, and here we can see that there is swelling. So obviously this is a case of inguinal hernia. Now we are not sure whether this is direct or indirect, because inguinal hernia can be of two types, direct or indirect. Now direct is, I already told you, it is seen in elderly, and there is a history of chronic exertion like constipation, laborers. Okay, and indirect is seen in children's without any such history. So this history is absent. So the very first point which help us to mark our answer as indirect is, of course, the age group. So Chaitanya, you're right. Okay, and secondly, what is the anatomical difference between direct and indirect? Direct, the entry is through the posterior wall. Clear? So the bowel, it enters into the inguinal canal through the posterior wall. So this is the route. But in indirect, the bowel enters through the deep inguinal ring. Clear? And then it will reach into the inguinal canal and will come out through the superficial inguinal ring. Clear? So this is the basic anatomy. The entry point is different. Here it is in the posterior wall, here deep inguinal ring. And since the spermatic cord enters through the deep inguinal ring, so this itself indicates that the content is moving into the inguinal canal through the deep inguinal ring. So both the factors are fulfilled, and therefore the answer is indirect inguinal hernia, right? So this is how we will make our answer. Dr. SK, absolutely right. Then moving forward, okay, we can just see the image here. this is the deep inguinal ring, this is the superficial inguinal ring, okay, and this one is the Hasselbalch's triangle. Now if the bowel loops enter and come out like this is indirect inguinal hernia. Whereas if the bowel loop moves like this is the sorry this one is, I'm absolutely sorry, this one is direct inguinal hernia, okay, and this one is indirect inguinal hernia. Clear? So this is how the entry of the bowel into the inguinal canal is the basis of differentiation, whether it is direct or indirect. Then moving forward, protraction of mandible. Now protraction means if a mandible has been pushed forward and then it is taken back. So suppose if this is the upper jaw and this is the lower jaw. Clear? So say this is upper jaw and this is lower jaw. If, and the movements are always in terms of lower jaw because mandible can move up next. If the lower jaw is taken forward, this is known as protraction. Clear? So it is taken forward. And when it is taken backward at its own position, this is upper jaw, when it is taken back towards its initial position, this is known as retraction. Okay? So, protraction, forward projection, retraction, taking backward. Now, retraction is done by posterior fibers of temporalis muscle. So, this is done by posterior fibers of temporalis. Clear? Protraction is done by both pterygoids, that is medial pterygoid and lateral pterygoid. So both medial and lateral. Right? This is one thing. Then opening of the mouth is known as depression. Clear? So suppose if this is upper jaw, then depression will be like this is the lower jaw. So you can see it has gone downward and the mouth is open. So this is also known as opening the mouth. So this is depression, and depression as it is in line with the gravity. So one factor is gravity, of course. Clear? And second is lateral pterygoid. So these are few movements of the temporomandibular joint which you should know and which has been asked frequently. Very good, Dr. Puneet, very good. And since the movement is in line with gravity, so gravity also helps. Okay? Then moving forward, inferior thyroid vein. Now we know that there are three thyroid veins: superior, middle and inferior. Okay? On both the sides. Superior, middle and inferior. Clear? So this is superior, middle and these are inferior. Now the superior and middle, they drain into the internal jugular vein on either side. Right? So say here this is left, this is right. Clear? So right side, right superior thyroid vein will go into right IJV, right middle thyroid vein will go into right IJV. Similarly, left superior thyroid vein will go into left IJV, left middle thyroid vein into left IJV. But both the inferior thyroid veins, right and left, they will drain into a common channel, and that is the brachiocephalic vein on the left side. Clear? So there is no differentiation as such. Both goes into a same channel, and that is the left brachiocephalic vein. So you see the right side and the left side both are draining at the same channel, right? So the answer here is left brachiocephalic vein. This is the answer here. Otherwise, for superior and middle, they go into the respective sides, internal jugular vein, but inferior thyroid veins of both the sides, they drain into a common channel, and that is left brachiocephalic vein. Clear? Please remember. Then moving forward, all of the following structures passes through the substance of parotid gland except. Now you need to remember one thing, that there are two parts of parotid gland, superficial and deep, and the parotid gland is, you can say, bifurcated because of the facial nerve. So the important point is that the facial nerve passes through the substance of parotid gland, but it does not supply it. That is one important thing, right? So this is one of the keywords. Parotid gland passes, facial nerve passes through the parotid gland but does not supply it. Please remember, okay? But does not, this is very important, does not supply it, right? So it means it is passing through the substance of parotid gland, number one. Then retromandibular vein also passes through the substance of parotid gland, and if you look into the substance of parotid gland, you will find the external carotid artery. Clear? So this is the external carotid artery and not the internal carotid artery. So the answer will come out to be the internal carotid artery. Clear? So here you can see this is the facial vein, facial nerve, extremely sorry. Then retromandibular vein and the external carotid artery, and these are present within the substance of thyroid. This is superficial part and this is the deep part. Clear? So this is all the extent of, this is all extent of parotid. Clear? So the structures which are present within the substance of parotid are the facial nerve, retromandibular vein and external carotid artery. And again I am repeating, the facial nerve is passing through the substance of parotid gland but does not supply it. Parotid gland is supplied by cranial nerve 9th. This is very important. Many times it has been asked. Clear? Yes, Dr. Punit. Right? So please remember. And this is how in so many, similar sounding terms, they'll trap you. Then moving forward, which does not drain into middle meatus of the lateral wall of nose. Now here, you can take few words first, like inferior meatus, then superior meatus and supreme meatus. Now why I am mentioning these? Because these are the ones where there is opening of a single channel. Now supreme meatus is also known as sphenoethmoid recess. Clear? So here there is opening of sphenoid sinus. In superior meatus there is opening of posterior ethmoid, and in inferior meatus there is opening of nasolacrimal duct. If you can remember these three meatus and the opening of these three sinus, everything else goes into middle meatus. So that is one simpler way of remembering. And yes, of course, the answer will be nasolacrimal duct here. So supreme sphenoid sinus, superior posterior ethmoid, and inferior nasolacrimal duct. Apart from this, everything will go into middle meatus. So you can see there are plenty of openings in middle meatus, that is middle ethmoidal, maxillary, anti-ethmoidal and frontal sinus. Clear? So that is all up to you how you remember the things. Sphenoethmoidal recess, that is supreme meatus for sphenoidal sinus, then superior meatus, posterior ethmoidal, and of course inferior meatus, nasolacrimal duct. So please remember it. Now a patient was operated on left submandibular gland but accidentally damaged his left lingual nerve. Now what will be the effect of the injury to left lingual nerve? Now left means the manifestations will be on left side because this is a peripheral nerve injury. The function of lingual nerve is to carry journal sensations from anterior two-third of the tongue. Clear? So there is general sensations from the anterior two-third of the tongue, and therefore if this nerve is gone, there will be loss of all these sensations on the left side. So very simple. General sensations. Now just what is general? Like cold, hot, all those sensations. Clear? Very good, Dr. Puneet. Very good. Now the question is, okay, you say anterior two-third and posterior one-third. Now what is this demarcation? How you can say that it is, this part is anterior two-third, this part is posterior one-third? How you will say that? So suppose if this is tongue, there is one sulcus terminalis. Clear? So this is sulcus terminalis, and this is the point of differentiation between anterior two-third. So obviously anything anterior to this is anterior two-third, and anything posterior to this is posterior one-third. Clear? So this is how you will understand this. Clear? So moving forward, a patient has extraction of third molar tooth, and after this the patient observed that there is loss of general sensations from the anterior two-third of the tongue and the floor of the mouth. General sensations, we have already discussed this. Anterior two-third of the tongue. I think everyone should answer this. The answer has to be, very good, Dr. Puneet, very good. This is nothing except lingual nerve. We just discussed it. So this is lingual nerve. Fine. This is how you can make your answer. Now, moving forward, what is the correct sequence of brain structures moving from outside to inside? So let us take the image first. Now what happens here, you can see this is, suppose if this is the insular cortex or insula, right? After that you will see this is the putamen. Clear? Deep to putamen is globus pallidus externa and globus pallidus interna, right? So there is putamen and then globus pallidus externa, globus pallidus interna. Externa, globus pallidus interna. Clear? Now if we combine these two structures, it is known as lentiform nucleus. So this is lentiform nucleus. Then we will get the internal capsule. So this area here is the internal capsule. Clear? So this is internal capsule. Then there is a small nuclei, and this is known as caudate nucleus. So this is the caudate nucleus here. So caudate nucleus here. And deepermost structure is the thalamus. So this is the thalamus. Okay, so here you can see this is the thalamus. Right, so if we go from outside to inside, this is lateral and this is medial. So what structures we can see? The very first one is insula, then lentiform nucleus, internal capsule, caudate nucleus, thalamus. So the answer will come out to be insula, lentiform nucleus, internal capsule, caudate nucleus, thalamus. And what is lentiform nucleus? Putamen plus the globus pallidus. Globus pallidus has two components. The outer one is externa and the inner one is interna. Clear? So this is how you have to oh, Dr. Puneet, thank you for informing everyone. But I think just a matter of 5 more questions, then you can jump onto your emails, right? So let me finish, gentlemen. And okay, I'll go a little fast, not an issue, right? So not seen in oculomotor nerve palsy. Now, if you remember the mnemonic SO4, LR6, rest by third. So if you say if there is paralysis of third nerve, it means these two muscles will be okay. SO4, because that is supplied by trochlear, and LR6, that is supplied by abducens. So these two nerves will work. Now, the action of SO is abduction, right, depression and intorsion. Clear? And the function of LR is abduction. So the patient will, abduction is actually lateral gaze. Clear? And depression is downward gaze. So the patient will have downward gaze and lateral gaze. It means patient will not be having medial and upward gaze. Clear? So that is one easy way of getting up to the answer, because this is carried out by muscles which is supplied by third cranial nerve. Clear? Then moving forward, all are the branches of trigeminal nerve except, now obviously optic nerve is not a branch of trigeminal nerve, it itself is another cranial nerve, that is 2. So here you see the 3 branches: ophthalmic, maxillary and the mandibular. These are the 3 branches of 5th nerve. Then moving forward to Frey's syndrome. Now here this is related to auriculotemporal nerve, and here there are 2 fibers. One is sympathetic and another is parasympathetic. So sympathetic and parasympathetic, and parasympathetic goes to parotid, and this results in salivation, and sympathetic actually goes to sweat glands, and this causes sweating. Now what happens when there is injury to this auriculotemporal nerve? There is some miscommunication, or there is some wrong communication, so that this parasympathetic goes to sweat glands. Because whenever there is chewing action, the parasympathetic is stimulated and it should tell the parotid gland to salivate. But after Frey's syndrome, this is stopped and this actually works. So after chewing, parasympathetic will reach up to sweat glands and will tell the sweat glands to sweat. So patient will start sweating on chewing, and this is known as gustatory sweating. Instead of salivation, there is sweating. So this is known as Frey's syndrome. Then moving forward to LMN right side facial nerve. So it means there will be affection of the same side, and since it is element, so complete one half paralysis. Okay, so complete one half paralysis. So how it will be seen? Like if suppose this is the right side here, this all right side will be paralyzed. So there is involvement of forehead and the lower part of the face as well. So this is how you need to remember. This is Elleman or Bell's palsy. Clear? So this is important here. Then last, a patient fell on, this is Fuchs injury actually. And the moment you have Fuchs injury, then tenderness in anatomical snuff box, there is no doubt as to fracture of scaphoid. Clear? So think of fracture scaphoid, post Fuchs injury, tenderness in anatomical snuff box. So these are the boundaries of anatomical snuff box, and of which the scaphoid forms the floor. The medial boundary is found by extensor pollicis longus, and the lateral boundaries are found by two tendons, that is extensor pollicis brevis and abductor pollicis longus. So this is in short about questions of anatomy. Yes, Chaitanya, you are absolutely right. So this is enough for this session. See you very soon with another subject. And thanks for giving your valuable time. God bless.